All right, everybody, we are back. Again, thank you to Cheryl, Kieran, and Genevieve for our first panel. And we are ready to start with our next panel, which is the importance of survivorship clinics and also discussing second cancer risks. And we have two fantastic panelists today, David Freyer and Yasmin Khan, who are both with the USC Norris Comprehensive Cancer Center, as well as Children's Hospital Los Angeles, a place many of you are familiar with, as I know we do have a lot of folks here who either receive treatment or whose kiddos receive treatment at CHLA. And they are both wonderful. I know this because I've been enrolled in their cancer survivorship clinic for probably 6 or 7 years and have seen firsthand the importance of a survivorship clinic, and you guys are going to learn an awful lot over the next hour. So I'm going to go ahead and turn it over to David. Welcome.
Okay, great. Well, thank you, Marissa, and the rest of the planners for this meeting, for the opportunity to join you for this always a wonderful meeting every year. And I've had the privilege of being involved through Marissa now for, I guess, 2 or 3 of the meetings, right, Marissa? And it's always really a privilege, and I want to thank you for that. I have a presentation that'll last about 15 or 20 minutes, and what I'll be discussing will be survivorship care after retinoblastoma. And I'm going to focus, of course, on what some of the medical considerations are, and hopefully this will be helpful for you. But I want to acknowledge right from the beginning that, there's survivorship care and then there's the spirit of survivorship. And one of the things that I'm always nourished by when I attend the One Retinoblastoma World Meeting is the spirit of survivorship care. It's very much a team effort between the patient and the medical team, to do it all. And I'm always truly inspired by the patients that I take care of. It's why I come to work every day, and it's what drives the research that I'm involved in, and most of all the care that has been my career now for a number of years. I'll start just by the basic question of what is cancer survivorship, and not to overdo something that's somewhat obvious. I think I just want to acknowledge that cancer survivor is a term that's been defined in a couple of ways. One is that anybody who has been affected by cancer from the time of diagnosis on is a cancer survivor. That's the patient, also family and friends. From a very pragmatic standpoint, and I believe very strongly philosophically that is a definition that makes sense. But I want to say that from a pragmatic standpoint, we often define survivor as someone who's completed cancer treatment. In a survivorship clinic, you'll see the term used that way. And a lot of what I discussed today in this presentation is sort of uses a little bit of both, but largely that pragmatic definition. Cancer survivorship as an oncology discipline is quite well established in pediatrics, not so much in adult medicine, but it's really anything aimed at maximizing physical and emotional health and quality of life after cancer. That's the whole point, is to make life better. And I think it drives a lot of what Yasmin and I do in our clinic. Now, cancer survivorship clinics are focused on the needs of survivors. We do several functions. One is to address side effects of treatment, that may occur long-term, to educate our patients and families about the health risks and very importantly, ways that they can reduce those risks and maybe even prevent them. And then we try to address a lot of challenges that are sort of part of normal life but are made different by living with a history of cancer. And those are emotional issues, development for young children as they grow through life, informational needs, and then of course financial challenges, which are very important. Our team is multidisciplinary. It always involves a physician, an advanced practice provider like Yasmin, social workers, many other therapists that I can't list here, like occupational therapists, physical therapists, vision specialists, and so forth. And what we all have in common, though, is is a shared expertise around the health problems that can happen after cancer treatment and a commitment to make them better. And of course, again, it goes really without saying, although I'll say it anyway, that probably the most important team member, without a doubt, is our patient and our family. And together, we accomplish what we aim to do. So I'll start by the next series of slides by kind of giving you the bottom line. This is the lesson. This is the point that all the rest of the slides will really make. Who should be referred to a survivorship clinic or for survivorship care? Really, it's any child or adult who has been treated for retinoblastoma, no matter what treatment that they had. And why is it even important to refer for survivorship care? It's to address health issues related to the retinoblastoma, genetic status, prior cancer treatment, treatment of late effects, and by late effects, we mean long-term health issues that may develop after treatment, health risks and wellness to, again, lower those risks and promote wellness to improve quality of life, and then very, very importantly, to offer psychosocial support and resources. This are some of the medical monitoring and management that we conduct. Of course, trying to ensure optimal vision is important, and it requires the expertise of ophthalmologists who are very skilled at this. And for those patients who have a prosthesis, to make sure that the fit and function of the prosthesis is excellent. We also screen for some late effects that can occur after some types of chemotherapy that are used to treat some patients with retinoblastoma. Some children are at risk for hearing loss because of receiving carboplatin in high doses. Neuropathy, which is sort of numbness and tingling in the fingertips or weakness of the fingers due to vincristine that some patients receive. And then sometimes screening for other late effects. And I didn't want to give a laundry list of those because actually with current therapy, most chemotherapy medicines are safe from a long-term perspective. But from time to time, we'll have patients who need to have their heart function screened, their kidney function screened, and so forth. And then on the right side of this slide, of course, everybody, I suspect, on this attending the meeting is aware that testing of the retinoblastoma gene is very important. And one of the roles that we conduct or perform is to make sure that that testing is complete and that it's been interpreted properly. I'll say a little bit more about the RB gene mutation in a moment. For monitoring for second cancers, again, if there's a germline retinoblastoma mutation, I'll say a little bit more about that, but monitoring for second cancers is a very important function that our clinic does. We partner with the patient and family to do that. Reinforcing genetic counseling and information. And then finally, sometimes there are other family members who may be at risk who haven't been fully screened, or something we see quite a bit of is that the child is in care, is in survivorship care, and we're seeing them, but then we start asking questions and find out there's a parent or maybe older siblings who have been treated for retinoblastoma and they're not in survivorship care, so we can kind of pull them into the mix as well. I'm not going to get too technical with the presentation, and I promise you this is the only curves like this that I'll show, but these have to do with the important issue of second malignancies. In this slide on the left side, you'll see a panel that has the heading more common with retinoblastoma gene mutation. What this is referring to are second cancers. And in this curve basically shows vertically the percentage of patients who develop a second cancer, and then the horizontal axis shows years after diagnosis, and the far out time point is 50 years, 50. And the top on the percentage is about 40%. And what this particular publication shows, and these are for patients treated, a number of years ago, so treatments have changed. But the top curve shows the percentage of patients who have the retinoblastoma gene mutation and the occurrence of second cancers as a function of time. over those 50 years. And what this particular cohort showed is that the cumulative incidence was about almost 40%, 36% or so for patients with the retinoblastoma gene by the time they basically reach 50 years of age, or 50 years from the time of diagnosis. And in contrast, on that panel, the lower one, which is much lower, that's flagged RB negative, means that their retinoblastoma or RB genes were normal. The incidence of second cancers is much lower. And then the other important point to make is on the right-hand panel, which shows the effect of radiation therapy. Thankfully, as you know, radiation therapy is used much less nowadays than it was, many years ago. But nevertheless, it's important to be aware that radiation therapy, as traditionally given, does increase the likelihood of developing a second cancer. And what this panel shows is that in the upper curve, those are patients who received radiation therapy. The lower curve are those who did not. So as you can see, retinoblastoma patients, even if they don't have radiation therapy, may develop second cancers. Those are almost always patients who have the RB gene mutation, but the risk is higher for those who have had it. Now, on a more practical level, what are some of the things that I think are important for listeners to know? And I invite you to maybe consider this information. So this is a list of common types of cancers that occur as second cancers. Tumors of the bone, tumors of what we call the soft tissue, leiomyosarcomas and rhabdomyosarcomas, those are muscle tumors. And then I won't go into detail with all these, but certain types of brain tumors, melanoma or malignant skin cancers, breast cancer in women, bladder, uterus, and so forth. These are listed roughly in order of frequency. So by far, the largest percentage of patients who develop second cancers, it's those top two categories of bone tissues tumors, or bone tumors, or soft tissue sarcomas. The kinds of symptoms that we like to advise our patients to watch for are masses that might occur, out of nowhere, especially if it's in an area of the body that previously received radiation. So that would be up around the eye area typically, of course, and this might be accompanied by pain or swelling. So masses in that area should always be taken seriously. Because brain tumors can occur, patients who might develop persistent unexplained headaches, and I want to emphasize the persistence and unexplained, because headaches are very common and we don't want to set off alarm bells for minor things that don't need worry. But if it's persistent or unexplained, or perhaps very severe, you'd want to bring that to the attention of the doctor. And then finally, catch-all of other persistent or unexplained symptoms, leukemias, which are very, much less common in survivors of retinoblastoma, can occasionally occur, and those symptoms are quite vague and difficult to pin down. So I would say, good advice is just to be aware of any other persistent or unexplained symptoms. I think it's always good to have a threshold to go, get seen and checked over for things that just don't make sense or are not explained by colds or other, viruses or whatnot that might move through anybody. For screening and detection, the foundation of this is actually self-monitoring, which is why education is so important. And we really emphasize this in our clinic, for what patients should be following for, what they should be kind of monitoring for. We try to find a balance of having people be aware of what to take seriously, but not to drive themselves too crazy by hyper monitoring themselves, if you will. And I realize that's much easier for me to say than it is to live, but that's what we sort of aim for. Of course, anybody, whether or not they've had retinoblastoma, might have screening that comes due for age for things like breast cancer, colon cancer. Those are normal things that all people should undergo, and those should be observed for sure. A question we get a lot is, what's the role of whole body MRI scans? That's a little bit newer, and it's a complicated topic and I can't spend a lot of time on it, or else I wouldn't be able to cover the other slides, but I'll just summarize that here. Maybe if there are questions about that, we can go into more detail at the end. I think we can summarize it by saying that currently the role of whole body MRI in monitoring retinoblastoma survivors has not really been defined. It has been used in certain other childhood cancers, choroid plexus carcinoma being one of them, which is not at all related to retinoblastoma. But in that, and those patients have P53 gene mutations, and some of you may be aware some very nice work has been done in that area that has, defined using good scientific evidence that whole body MRI scans, do play a role. We don't have that as yet, at least to the best of my knowledge, in retinoblastoma, and I kind of keep an eye on that literature. So we're not using it routinely, but I recognize that some providers may be recommending that from time to time, and I'm not here to say that's wrong, but there isn't a strong evidence base for it as yet. And then finally, cancer prevention is something we're very, obviously very enthusiastic about. So trying to avoid unnecessary radiation, unnecessary x-rays or CT scans. I say unnecessary because sometimes they are necessary to evaluate certain problems. And if so, one should not worry too much about getting those done because there's a risk-benefit ratio that may favor that. But just routine scans, we would say not. Sunscreen, very important to avoid skin cancer, and of course, avoiding smoking, vaping, putting other things in our lungs, excess alcohol, and then trying to maintain good nutrition, physical activity, and normal weight are all important. Now, psychosocial support consists of just helping patients adapt emotionally to changes in vision and functional differences that they may have. We really work hard at trying to support children feeling accepted, building their self-confidence, and mixing with peer groups so that they can enjoy life. We try to support this with guidance that we direct toward the child and the parent. Sometimes psychology consultation is important. Ensuring school recommendations is very important. We tap into our school specialists at our hospital to make sure that any vision accommodations that are needed are made available to the patient. And then very important is connecting our patients and families with support groups, wonderful organizations like this one here, to educate them, give them a sense of community to help them move forward in life. Now, some of the health information and health promotion that we undertake is to educate our patients about the risk for late effects and opportunities for reducing risk. I've talked about some of that here, but I want to mention that I think it's important for cancer survivors to know that there are many things that are within control to change life for the better. We can avoid hearing loss by avoiding unnecessary loud noise, for example. If patients have some degree of neuropathy, we can recommend physical therapy. Avoiding heart damage or heart late effects, cardiomyopathy for those who are affected through exercise, weight control, and diet, as I mentioned. And then we can do a lot to avoid first or second malignancies by using sunscreen, avoiding smoking, avoiding unnecessary radiation, and so forth. And then I've already spoken about the value of general health measures. Those are really important to emphasize. Now, financial challenges are really an important area that are getting a lot of attention in research right now in cancer survivorship. Our goal is to achieve the ability to get the long-term survivorship care that patients need to have. And that requires health insurance. Now, a lot of my comments here are going to be aimed at listeners who live here in the United States. There are many wonderful things about our healthcare system, but one of the challenges that Yasmin and I and our patients run into frequently is the patchwork nature of it. It's privately based, mostly employer-based types of health plans, not uniform, widely available, population-wide, health plans that are primarily administered by the government. There are pros and cons, obviously, for each, and I'm not prepared to really argue that on a broad level, but I can say that our system here in the US offers a number of challenges. What I like to refer to as what I call the golden triangle of education and vocational training, employment, and health insurance to make it all work to get health insurance and therefore survivorship care that patients need over the long haul. And very briefly, what I mean by that is that one leads to another. At the top of the triangle is getting the education or job training that's needed to get a good job. What's a good job? Well, part of it is something that you enjoy, obviously, but the lower left triangle point is employment with benefits. And so a job with benefits is extremely important. And what do we mean by benefits? There are a lot of things with that, but one of them is health insurance, and that's the right-hand triangle point. So we try to educate our patients that that education, finishing high school, going to college, going to get vocational training so that you can enter a field that offers, again, good employment opportunities with benefits, is what leads to health insurance, which is then what that person needs as a long-term cancer survivor. Being without health insurance is a real problem, as Yasmin and I can attest to every time we have clinic. The last kind of major point I'll make is healthcare transition, and this is important because retinoblastoma is diagnosed in childhood, young childhood specifically, and survivorship care is needed throughout that life as a child. But all children grow up eventually, and when they turn 18, 19, 20, 21 or so, they sort of shift over into the adult world, and that includes for medical care as well. So getting survivorship care as a child is important, but then making sure that care continues lifelong is also equally important, because adults have healthcare problems that need to be attended to as well, even though it was a childhood cancer. So transition is what we refer to that process. We start planning early by educating our patients fairly early, starting around 13, 14, 15 years of age, so that by the time they reach 18, 19, 20, they're already familiar with this concept. Identifying adult healthcare partners that can work with our team, develop a survivorship care plan that Yasmin is going to go to in more detail. Insurance, again, is don't leave it to chance. We need to plan for that. We try to make that point, and then really educate and empower our patients and families to know what they need so that they can advocate for themselves and get it. The approach that we use here at CHLA and USC is just one approach, and I'll just share that with you as one way to do it. We see our patients at Children's Hospital Los Angeles within 2 years of ending treatment. So these children are 3, 4, 5 years of age when they enter survivorship care. They're seen in our clinic once a year in parallel with the treating oncologist and the ophthalmologist who keep a close eye on them. And then when they turn 21, we transition them to adult providers. Now, if they're in the world of retinoblastoma, if they're higher risk, and what we mean by that is that they've had radiation therapy and or certain kinds of chemotherapy and or they have a germline retinoblastoma mutation, then they're referred to our higher risk clinic, which is the Life Clinic at the Adult Cancer Center, USC Norris. If they're lower risk, actually, which is what most of the retinoblastoma, the other survivors are, who don't meet the criteria that I mentioned there, we actually cut them loose from all of this stuff and recommend that they follow with their primary care provider, although they do go out the door with a survivorship care plan. Now, I recognize that there are probably listeners here who are not in survivorship care, and a question that sometimes comes up is, well, gosh, I'm way out of childhood, I'm an adult, and it sounds like I should be getting survivorship care, but I'm not in it. What should I do? Here's a couple practical approaches. One is, if you know that you're in the lower risk group, which means that there's no RV gene mutation, no radiation used, no intensive chemotherapy, this should be relatively straightforward. Make sure you've got a primary care provider to get an annual checkup. Good idea to have an ophthalmologist, obviously, to follow vision and make suggestions there. And of course, if there's a prosthesis in place, having a good prosthetist is key. If a person is in that other category on the right, which is higher risk, meaning that there's a history of an RB mutation or the status of the RB gene is not known, and if there's been previous radiation given, I would say try the best you can to identify a specialized survivorship program, either pediatric or adult. And at that center, get RB gene testing if you don't know the results of it, and then begin annual checkups with the survivorship team. So again, to recap kind of what I've covered, who should go to retinoblastoma, or who for retinoblastoma survivors should receive a survivorship care? Well, any child or adult who is treated for retinoblastoma. Why? To maximize health and improve quality of life, make it the best it can be. That's what survivorship is all about. When should it start? Actually, soon after completion of treatment, or as soon as this presentation's over, you can get started. And then where? A survivorship clinic, if available. There are some ways of finding lists for that, at least in the United States, and I presume in other countries as well. And we could provide more information on that in the question and answer. And then finally, for how long? Well, lifelong, actually, and certainly that would be true for higher risk survivors. So that's the conclusion of my message, and I'm going to turn it over to my expert in arms, Yasmin, and I thank you for your attention.
Hi, everybody. My name is Yasmin Khan. I'm a physician assistant at USC Norris Cancer Center. And let me share my screen. Thank you so much, Marissa, for this opportunity. Okay, so the main thing here is you're done with cancer treatment. You're done with treatment and now are cancer-free, but what's next? A lot of patients come to our clinic saying that, okay, I don't know what's next because I no longer see my doctor, or I've grown up and now I am an adult and I don't know what's the next step to do. So welcome to our survivorship clinic, or welcome to survivorship in general. What is a survivorship care plan? Well, it's really important to know what it is because it's a complete and concise treatment summary of everything that's happened to you as a cancer patient. It's permanent, it's mobile, and what I love to tell everybody is that you can take it to any place in the world. Any clinician, any hospital, in any country in the world will know what you've gone through medically. And that's really the key part about what these care plans are. Why a specialized clinic? Well, see, I'm a little partial to ours, but here's the thing. I've been in practicing medicine since I was for a long time, and it's been about 23 years, and I didn't know survivorship was a specialty. And now that I'm here, I am floored by what we do in our clinic because it is so specialized. You know, as a patient, you're in a new phase in your life. It's a chance to feel empowered about your health because you're learning all of the things that you need to be doing to stay as healthy as possible. You get to build resources and make contacts with people, and you get to really move forward with knowledge to be your best advocate, to gain a team of advocates. Any patient of mine knows that I'm one of the biggest advocates for them because I really go out of my way to make sure people know what the next step is in their journey, and I'm there to cheer them on the entire way. Also, as you move forward and as you get older, your medical needs have somewhat changed. So we need to actually make sure you know people who are aware of the needs that are happening. And also, the guidelines change every few years. So you want to make sure that you have up-to-date guidelines to follow to maintain your health and know what's coming down the line for you. And once again, clinicians who specialize in this. Finding a clinician or a physician who specializes in treating and preventing late and long-term effects of your treatment is pretty gold because of the fact that they really will go out of the way to make sure you know how to advocate for yourself. So the question is, how do you get a care plan? Well, there's more than a few ways. You can do a few things. You can ask your oncology team. They should know how to get you a survivorship care plan. You can speak to your primary care provider who can do some research and find you a survivorship care program, or have you go to an oncologist. Once again, I get a referral to a program, or you can kind of piece together and make your own. There's a couple of websites that we like to tell people to go just to look at, and I'll get to that at the end of this. And the next thing to know is, how do you prepare for your visit? So the first things first is get an appointment. So if you are a PPO, so for everybody in the US, if you either have an HMO or a PPO, HMO means that you need to get a referral to come to a clinic, and a PPO means you can go to any clinic that you'd like to go. First, get the appointment. That's number one. So it means either getting your doctor to refer you or finding a clinic. But then that's where the work starts for you, so you can help the clinicians be the better advocate for you ahead of time. You want to get your information, treatment records. You want to get your last oncology note. You want to get what chemotherapy you had, if you had radiation. You want to get your genetics notes. It's important to know so we can figure out your risk and how to make sure we monitor you for your late and long-term effects. Any type of treatments or tests that you may have had to take care of yourself, like echocardiograms, DEXA scans, pulmonary function tests, MRIs, anything related to your cancer diagnosis, and bundle it together and send it to the oncology clinic that you're going to at least 2 weeks ahead of your appointment. And the reason why it's so important is preparation. If you see how these charts are put together, the clinicians review your entire history and put together a preliminary summary of all the things that you need. You know, we go over the most current guidelines, and we assess possible risks and where there's also minimal risk, so we don't waste your time. Your time is respected. We want to make sure that there's no duplicate scans. We want to optimize your time in your visit, because honestly, time is our best currency. It's what we can give to people and never get back again. As adults, we know everybody is busy, and we don't want you to have to take a day off from work if you don't need to. Also, what happens here at the visit? It's a couple of things to know. Once again, survivorship is optional. It should be mandatory, in my opinion. It's in everybody's best interest. However, it is optional. You don't have to go. But if you do go, the visit lasts about an hour, sometimes longer, sometimes less. Different programs do different things. At ours, you see myself, you'll see a Dr. Freyer and our social worker. And depending on what your treatment was, or what you've had in the past, or what you have going on right now, you may get labs done. You may get MRIs ordered. As David said in the previous presentation, we'll do our best to minimize any type of radiation exposure you have. I can guarantee if you come to ours, you'll be referred to ophthalmology. You might be referred to genetics. You'll get to the subspecialties that you need, the services that you need. So in our clinic, once you send us all that information, people get a little irritated. We'll take a whole new history. And the reason why is that getting history from a piece of paper is different than getting history from you. And so we'll do an entire history on you. We'll talk to you about everything that's going on, whether it's related to your cancer or not related to your cancer, because all of those things at some point combine and are really important. And then we'll do an exam, and we check you from head to toe. And the reason why is because we're looking for late and long-term effects. We hope we don't ever find them, but we're looking for stuff that maybe your general practitioners don't know what to look for. And so we're trying to make sure that we're as thorough as possible to give you the best chance of staying as healthy as possible. And the thing is we're all busy, so we really want to make sure we utilize our knowledge to not have to order other things, not have to order extra scans. And we're really well aware of the financial toxicity that comes with cancer. So we want to minimize your co-pays and deductibles that you have to meet. So we really do our best to do an examination and make sure everything that we order is absolutely necessary for you. But now really why come to our clinic, or a clinic with practitioners that you really like and care? We really spend time getting to know you. We talk about we ask the hard questions. We talk about body image. We talk about relationships. We talk about sexual health. We talk about your expectations for yourself. We really drill down on your hopes and aspirations and ambitions, because we really believe in treating the entire patient, not just the disease. And we talk about things like chemotherapy and adaptations for work, because we really want to set you up for success and help you be the best advocate as possible. We talk about sexual function and dysfunction. We have actually referrals for this because it's part of life, and people are afraid to ask those questions. And then we talk about other things like, why it's important to have a good relationship with your primary care doctor, why it's important to have dental checkups and other cancer screenings because of those secondary cancers. And now the next thing in our clinic, what happens is we talk to you, we give you your care plan, and we speak it out with you. So at this point, we've put together all of the information gathered from prior to the visit, and then during this visit to tailor the care plan specifically to you. And we talk about the review of your treatments you had. We discuss your risk of possible late and long-term effects. We give you monitoring suggestions. And then my favorite part of the visit is we also talk about what is no longer an issue. The part that I enjoy the most is we take some risks away. And in our delivery of the care plan, we really utilize the latest and greatest research. We talk about the guidelines on preventative medicine, and we really cater it specifically to you. So when it comes to retinoblastoma, Dr. Freyer covered this before in the previous presentation. Genetics is really important in making sure that, as I drill this into every one of our patients, is that you have to be the carrier of your records, and then you have to make sure that your survivorship clinician and your primary care provider are also the carrier of your records. It's like a conductor of an orchestra. You want to know if you have the retinoblastoma gene. If you do, have your parents gotten tested? And if they've gotten tested, are they positive? It's really important because we want to look at what risks are there and how you can stay as healthy. We want to talk about family planning, what other cancers are you at risk for, give you some advocacy. And if you don't have the genes, do you really need increased screening? So for patients who are RB1 positive, we want to talk about secondary malignancies, as David spoke about, melanoma screening, soft tissue sarcoma. If radiation has been part of your treatment, we talk about secondary cancers in that area. And then we talk about family. We really do believe in making sure your entire family is protected. So if a child is positive, the parents should get tested. And if the parents are positive, then all the child's siblings should get tested. And making sure you get seen by genetics. These are things that we can help advocate for you, and that I would happily do. And if anybody has had retinoblastoma in the past, can they see the survivorship specialist too? We can see families in our clinic. Some other things that we talk to patients is family planning. And that's why it's important for genetics to get involved, is preconception counseling. Why is it important? What are some other reproductive options that you might have, like IVF or donors or adoption or testing after birth? And those are some things that we'll have a discussion with you, or refer you to the specialist who could actually have that discussion with you. So now I understand that not everybody is able to get to a survivorship clinic, and that is unfortunate. However, we're working on better stuff in general for our clinics. So here's what you do if you don't have one. Ask your oncology team for a list of all your chemotherapies, immunotherapies, radiation areas, and dosages of the radiation. Ask your oncologist to get your genetic screening information. Does it change your health screenings? Does it mean that you have to do more? Does it mean you have to do more testing? What does it mean for you? These are the questions you're going to ask your doctor. Here's my information. Here are the medications I've taken. Here's the chemotherapy I've taken. Here are the areas I've been radiated in. What do I need to do to stay healthy? Ask your team if anything changes, and take that information to a good primary care physician, because a good doctor will do the research to help you find that information. And that's really the end of my presentation. If you have more questions or questions, I'd love to answer. But here's my contact information. If you have any questions regarding screening concerns, what I want to really impart to a lot of patients is this: you have to be your own advocate. And then once you become your own advocate, you'll find other advocates like me who can help you with your journey. And when I think about the patients I've seen, this is what comes into my head. Your life is your own story. Write it well and edit often, because that's what life is all about. Thank you so much.
Thank you so much, Yasmin. I wholeheartedly agree with you. Are the only person that can take control of your survivorship journey. And for anyone in the Los Angeles area, the California area, even on the Western United States, who was not enrolled in a survivorship clinic, I cannot speak highly enough about David and Yasmin and the care that I have gotten from their clinic. And they're just also wonderful humans. So thank you very much. And I know we have a question, so I'm going to throw it back over to Sandra. And then if you want to raise your hand or put your questions in the Q&A, Sandra will get to them.
Okay, thanks again. They were amazing presentations. David, so good to see you again. And I'm still trying to get a survivorship clinic going in Melbourne.
Okay, so my question would be, so my son, my retinoblastoma survivor, David, He's 18 years old, and we will continue to be able to visit Children's Hospital Los Angeles for ophthalmology. But we have Kaiser now, which is a change for us. We've been told that we should join the life clinic at Kaiser, which I'm willing to do I don't have a choice, so which I will do, but I just want to make sure that, he's getting the best care as possible, because we're used to the life clinic at Children's Hospital, that's followed him since his whole life, since 2003. So I guess it's more of like a navigating insurance question. And he's currently, no evidence of disease. So if he, if he's continued, then we're not as concerned. But like I guess more the question is like, how do you transition from, the clinic that they know everything, they followed him, have his records for his whole life. And then we're being told that we need to switch. So, and he's adult now, so it's different.
Yeah. Hi, Lori. I think that this is a tough situation that does come up not rarely. Insurance contracts are what drive medical care more or less now, in the United States. And so your situation, if it makes you feel slightly better about it, you're not alone by any means. This is a really common problem now. I actually don't know what the status of survivorship clinics are within Kaiser at the present time. I have professional, colleagues and friends who are in Kaiser, and I haven't checked on the status of that for a while. I don't know if they have, kind of a dedicated clinic or not. They might. And if they do, I would certainly recommend, tying into that. Take the last survivorship care plan that you have from the life clinic at CHLA, take it with you. They would be able to scan it up into their system, and at least they could kind of work from that information base that they have. And then, we're readily available, more than happy to talk with anybody if they want to call over to sort of check into things, or from you, if you want to check in with us at any time. Like I like to tell our patients, once you're sort of in our clinic, you're kind of part of the family, and you'll always be part of it. So no matter what happens, so you're always welcome to, kind of check in with us if there's something you want to bounce off of us, get our input on, or something. So that would be my suggestion. I'm not going to necessarily recommend this, but just so that you're aware, we have had occasional Kaiser patients who just are, they're adamant about wanting to go to the life clinic at CHLA or USC, and they'll pay out of pocket for it. I'm not recommending that, but by any means. But
it's an option. It's an option. Yeah.
It's an option.
That's good to. That's good to think about. Yeah.
Also, I actually heard recently through friends who actually are building the clinic in the South Bay. They actually are in the process of trying to build. They were in the process of building a clinic for survivorship in the South Bay. Unfortunately, COVID happened. So I'm not quite sure where they're at with that journey yet. But also, if they don't have this in Kaiser, what I was told is if this is a need that you have and they're not able to provide it to you, you have to ask for a referral out. And they can refer out. They don't always. If they can have an oncologist help you with it, they probably will not refer out. However,
right.
I see the clinic notes that they give you from the survivorship clinic at CHLA, and they have everything that most clinicians will need to really take care of him. I know it's scary, and I don't know what it feels like to be in your shoes, but I do know that they prepare you really well at CHLA for the transition. Because I get them here afterwards, so I know how prepared they are.
Yeah, I mean, so far, the transition hasn't been good, but I think that's also due to the complications with COVID. I mean, and fortunately, he has been seen in person at Children's Hospital. So like for right now, everything really is fine. And I keep trying to remind myself of that, but just going forward, so far, because of the, telehealth or video, I haven't felt very comfortable, and I'm going to keep trying. because I think like his in-person appointment with Kaiser, the oncology, pediatric oncology life clinic, I mean, it would be in this next summer. So like, at least we're not behind in our care, but I'm not feeling confident with it. So it's you know, it's a new doctor, and it hasn't been a good transition so far. So.
Well,
Okay.
good luck with that, and don't
Thank you.
to reach out to us if needed.
Good luck with that.
Thank you so much. But that is a good idea. Yeah, just paying out of pocket, doing what we feel more comfortable doing. So thank you.
Okay, the questions are coming in thick and fast. So from Vera Esserman, what minimum services or requirements are needed to set up a survivorship clinic for teens or adolescent survivors? Vera from Ghana.
Well, I can take a stab at that. I think what's needed is a core group of people who are committed to this area and committed to the patients and their needs. In terms of the infrastructure and the basics, I don't think a lot is needed. I think that there needs to be a place to see patients. There needs to be a little bit of support staff, you know, to make it work. But I don't think it's super resource heavy. Now, depending on how much screening is done for late effects, you may need access to things like cardiology, radiology, pulmonary function testing, a basic lab. You know, those are always helpful. I'm trying to think of situations where maybe resources are very limited. I think that resource limitations may make it a little bit more challenging, but I think at the end of the day, what's needed most is somebody to drive it, somebody who's passionate about this, who will, you know, bring people on board, bring the institution on board, make the case, explain why this is so important for patients. Yasmin, do you have anything you want to add to that?
I absolutely agree with everything that you say. You need someone who's going to drive it and kind of push it forward. That's the key part about all of it. You need medical care outside of survivorship, because you will have referrals that are not something that's your specialty. I couldn't read an echocardiogram if I tried right now, but I know that my patients need it. So I'll need a good cardiologist to take a look at that and get that resources. So I think the most important thing, though, as David said, was really getting someone who wants to drive it forward and really believes hard in the cause.
Okay. So still lots of questions, and I don't know that we're going to get to them all. So I'm just trying to condense a couple into one question. There's a question from Pernilla Gregerson, and Abby White's is similar, around how to ensure international knowledge sharing between medical professionals at RB survivorship clinics. Can we create a network collaboration, and especially around the new and emerging evidence, screening protocols for survivors with RB1 mutations, particularly those who've had radiation, because that group of people, you know, we see that the late effects are still ongoing.
Mm-hmm. Well, thank you for the question. And Sandra, I just wanted to say, I know how difficult it is to monitor and coordinate responses with a Q&A chat type of thing. So nice work, and you have my my respect and admiration for being able to do that. So I think the answer to this question, I guess one thing I would say, I would sort of reassure, is that, you know, there's a lot of international collaboration in the world of childhood cancer survivorship. I mean, there really is. This is on the radar of, you know, around the world. And there's increasing, I think, especially in the last decade or so, we've seen the organizations come together to where specialists from many different countries are meeting, well, maybe not in the COVID era, but it'll happen again, and certainly was happening before COVID, you know, meeting in person on a regular basis internationally. In the world of COVID, okay, there's Zoom calls, but, you know, there's a lot of work being done to harmonize follow-up recommendations for patients like those treated for neuroblastoma. You know, how often do you screen? How often do you, you know, do this test or that test, and why? So I guess I would just throw that out there as maybe a reassurance that there is a lot of dialogue, you know, going on about that. Now, in terms of casting that net even wider, though, beyond health professionals and, you know, linking up with patients and families, I think that's what this organization is so good about. And one of the things I love about being able to participate with One Retinoblastoma World is that it does bring in all the stakeholders. You know, it's the healthcare professionals, but, you know, really the heart of it are the patients and the families and, you know, caregivers and other, you know, other stakeholders. So I think this is a wonderful venue for getting, you know, sort of promulgating the, you know, the most recent evidence and getting guidelines out there. I hope that answers your question to some extent.
Okay, thank you.